Good morning, everybody. Thank you, Debbie, so much for such a warm, welcoming introduction. I was just telling Debbie that we're always so thankful to be back in Hawaii. Michelle and I used to live in Los Angeles and would come here fairly often, got married on Kauai, and just feel that the people here are really, really incredible, so welcoming and warm. So we are really honored to be here with you today to share some information and a conversation, really, about dementia, share some of our learnings and successes and recommendations. Admittedly, we have a lot of information that we're going to cover. So my recommendation first is to buckle your seat belts because we're going to cover a lot of ground. But I promise every single one of you is going to leave this training feeling like you've learned something new and with a greater degree of confidence and self-assuredness about working with clients who are cognitively impaired. So as we get started, I want to share with you a little bit about the overall objectives for the day. And it really boils down to three things. We want to make sure that all of you have a really solid basis of understanding regarding dementia, like Alzheimer's disease. We're going to drill down a little bit more specifically about two detection tools that you can use when working with older clients to tell the difference between who may be impaired and who is not. And then probably most importantly, in the afternoon, we'll be talking about local resources and how best to connect people to the supports and services that they really need to live well and stay at home. So as Debbie mentioned, I'm a neuropsychologist. Many of you probably don't really know what exactly that is, but I work in the Department of Neurology and spend most of my time doing brain testing with older adults to get down to the bottom of their memory loss condition and make a specific diagnosis. But diagnosis is not really my passion or Michelle's. Our passion is making sure that after we detect cognitive impairment, older people with dementia thrive and live as well as they can, and that their families know what to expect, are prepared for the future, and well connected. And so I hope that today will give you some additional resources for ensuring that Hawaii is even more dementia capable. So if you look at your packet, your agenda, and on the screen now, this is just a little bit more of a breakdown about the day. I'm going to start with some foundational knowledge about Alzheimer's disease and dementia, understanding that we probably all come to this room from slightly different viewpoints and experiences. I want to make sure we're all on the same page. Then we'll take a break. We'll get into the tools that I mentioned. After lunch, we'll have an opportunity to actually practice administering some of these tools and delivering feedback to each other about our performance. And then the afternoon will be more about local resources. So what I'm going to do, starting off the morning, I'm going to talk about why Michelle and I are here, why dementia capability is so important for Hawaii, why you're on the cutting edge. And then we're going to define Alzheimer's disease, signs and symptoms, and explore the way that the disease progresses as people get older. Sound okay? Okay. So I'm going to start with a video. This is a woman named Wendy Mitchell. Wendy has young onset Alzheimer's disease, and I would like to share just a little bit of her story as we get started here.
My name is Wendy Mitchell. I have two daughters. This is a picture of us on a day out on holiday in Spain. It's rare to have one of us together, as I was always taking the photos. So this one is very special, as it was such a happy holiday. But unlike some families, I know the day will come when I don't recognise my wonderful daughters and what makes them so special. I was diagnosed with young onset Alzheimer's. Excuse me for reading my words, but if I don't, I'll simply get distracted and start talking about anything and everything. I worked in the NHS for 20 years. I'd always been renowned for a brilliant memory. I didn't forget. But my memory started to let me down badly. The worst episode was at work. I came out of my office one day and just didn't know where I was or who all the voices around me belonged to. When I actually received the diagnosis, I was bizarrely relieved, as it put an end to all the uncertainties. I was a very private person before dementia, but was so shocked at the lack of awareness and understanding that I'm now willing to shout from the rooftops. I write a daily blog called Which Me Am I Today? As my memory fails me more, so the blog has become a place where I can save all those special memories of events, thoughts and feelings. My other special place is my spare room. This I call my memory room. Whenever I go into that room, I know by looking at the pictures that they'll bring a smile to my face. Despite how my life has changed over the past year, I try my best to remain a very positive person. You can still live positively and independently if you accept that changes need to be made. People often ask me, what's it like? Well, every day is different. Most of my days at present are fair to middling. But on bad days, it's like a fog descends on the brain and confusion reigns. My way of dealing with these moments is to tell myself, it's not me, it's the disease. Imagine a bookcase as tall as me. It's a cheap, mass-produced flat-pack bookcase. This bookcase is full of books that contain my factual memory. My top shelf holds very recent books, such as What I Had for Breakfast this morning. But my shoulders are books from my 50s, and by my knees are books from my 20s, until you get down to my feet, where there are books from my childhood. Dementia rocks my bookcase side to side, and the books fall from the top shelf first. So what I think as my most recent memories will come from further down the bookcase earlier in my life. From what I've said so far, you may think a person with dementia loses everything, but actually I've only shown you one part of the brain so far. There is another part of the brain, which you can picture as a separate bookcase. This bookcase is sturdy. This is my emotional bookcase. When dementia rocks this bookcase side to side, it's stronger and more resistant. So the contents will be safe for longer. Even though I may forget that my friends or family visited me recently because that book comes off my factual bookcase, what stays with me are the feelings I had of love, happiness and comfort. I may forget what we did, what we spoke about, or that you popped by. But I know that I feel safe and happy when I see you. So please don't ever stop visiting me.
So I share this video with you as we start today for a couple of reasons. Number one, of course, it's people like Wendy that are the reason why we're here and why Michelle and I are so passionate about working with people with cognitive impairment. But also importantly, to show you a different face of Alzheimer's disease, somebody who's a bit younger, less impaired, articulate, aware, able to advocate for herself, express her needs, plan ahead, get connected to resources. And of course, all those things are possible because her disease was detected early. And so we're going to talk this morning about why it's so important for all of us in the community to be aware of dementia and what we can do to help our community members to be more aware of what's happening to them. So why are we doing this? And this is making Hawaii dementia capable. Well, the first thing that it's important for you to know is that cognitive impairment and dementia is much more common among older adults, much more common than you probably know. So I apologize, my very first statistic is a little bit outdated. They just came out with a new one that adjusted this number to 1 in 10. So 10% of older individuals above the age of 65 have dementia, Alzheimer's disease, or another dementia. So think about all the conditions that affect older adults. This is not a needle in a haystack. It is exceptionally common. In fact, if you and I are lucky enough to live into our mid-80s, the chances that we too will have Alzheimer's disease or another dementia are between 1 in 2 and 1 in 3, just based on age alone. Nothing to do with your genetics, your family history, just age, almost 50%. As you can see from the bottom graph, you know this already, as the population ages, of course, the numbers of people with Alzheimer's disease and related dementias continues to climb. Unfortunately, the numbers, the base rates that I just showed you, are for predominantly Caucasian Americans. And we know that there are some populations that are disproportionately at risk of developing Alzheimer's disease as they get older, and you see those listed on the screen. African Americans, for example, get Alzheimer's disease at twice the rates of their white counterparts. Older Latino, Hispanic individuals at 1.5 the risk. And you see at the very bottom, women also at a twofold risk of getting dementia. Now, the reason for that primarily has to do with, on average, women live more than 7 years longer than men, and so just because of age, they're at a greater risk. And scientists are also looking today at other factors, hormonal and other things unique to women that may, over their lifetime, increase their likelihood. So the interesting and sad part of this is that although Alzheimer's disease and dementia is very common, most people with these conditions don't report it to anyone. And of course, you can imagine why this is. There's a tremendous amount of fear, tremendous amount of stigma about having dementia, and frankly, really not knowing what normal aging looks like. So how can we tell the difference if we don't know what's normal? How many people in this room feel like they got a really solid education about what normal brain aging looks like as a person ages in their 70s, 80s, and 90s? Nobody? Right. So if we don't know what's normal, it's pretty hard to tell accurately and early what's not. And this is true for physicians as well. We'll talk a little bit more about that in a second. Lack of knowledge about what can be done. And of course, if you have Alzheimer's disease or dementia, you may know that it attacks the front part of the brain eventually, which is responsible for awareness and insight. So people with the disease are forgetting that they're forgetful. So they're not reporting it because they don't know. Now, also sadly, we know that today, less than half of people with dementia are ever diagnosed. They never receive a diagnosis. It's never detected. So again, by a show of hands, I'd like to see how many of you have sought out support and resources for a healthcare condition you did not know you had. Right, nobody, again. We don't do that, right? If you don't know what you have, you're not planning for it. You're not connecting to resources. And that's a huge problem in the context of Alzheimer's disease. So less than half of people ever get a diagnosis. And first and foremost, this has to do with ageism. The idea that as we get older, a little bit of senility is just normal. We know that's not the case, but it is something that a lot of people carry around with them because of messages in society and our culture. And there's lack of training among healthcare providers. The pace of research has been really accelerated in the last 10 to 20 years, and many physicians and nurses went to school, decades ago and haven't been given the tools and resources that they need to do this work simply and easily. Now, we have a whole nother training curriculum that we use for doctors and nurses and healthcare providers to give them that information and those tools. And so you may be asking yourself today, as you hear us talk, why we're asking you to help us detect older adults with cognitive impairment. Isn't that really the job of the healthcare system? Of course, it would be nice if our healthcare systems were completely up to speed, but until they are, it takes all of us as a community to have our eyes and ears open to be part of the solution. So that's why you're here today, and we'll talk more about that as we go along. This bar graph just shows you that in comparison to the four most common forms of cancer, high blood pressure, cholesterol, all of these other health conditions that affect older adults, most of the time in those disease states, people get a diagnosis. But with Alzheimer's disease, again, less than half are ever even told about their condition. When a diagnosis is made today, on average, we're making that diagnosis in the mid to late stage, when people are failure to thrive. In other words, it's an emergency. They're no longer safe at home. Now ask yourself, is that really the best time to recognize a brain disease? Is that the best time to intervene and support people? Probably not. And it's another reason why we are promoting earlier detection. So to summarize, less than 20% have ever discussed memory issues with their doctors or nurses. By the time a diagnosis is made, it comes 5, 6, 7 years too late after symptoms have been apparent for quite a while. And without a diagnosis, it's pretty hard to get connected to the care and supports that people could really benefit from. Now, on the other side of the coin, what you should know is that research shows we do not do a good job of detecting cognitive impairment early in a casual conversation with somebody. And so we need a validated tool to say yes or no, this person has impairment. And again, we're going to show you 2 of those tools today and give you some chance to practice, because you don't really need to know what is normal or what's not. You just need to use the tools and allow the tool to tell you who may need some greater assistance. So why are we doing this again? Dementia-capable information and referral professionals, case management, other community professionals help to create an age-friendly and dementia-friendly community. And the screening that we're going to teach you allows us to be more proactive, less reactive, and connecting people to resources earlier so that they can stay at home for longer. So very briefly, before I tell you a little bit more detailed information about dementia and Alzheimer's disease, I want to compare and contrast to normal aging. So in normal aging, you know that it's common for your hearing, your vision to decline, our gait or our walking, the speed of our body movement slows down. But thankfully, as we get older, we accumulate life experiences and wisdom, and our intelligence remains stable. We keep our intelligence when we're aging normally. Also in normal aging, though, there are some normal, mild changes that happen that affect the brain. And the first one is that our speed of thinking reduces. So after the age of 30, it's all downhill from there in terms of the speed of your thinking. So as people get older, sometimes memory loss can just be mistaken for this normal lag time a little bit. It's sort of like using a computer that is probably maybe 10 or 15 years old. Maybe eventually you're going to connect to the internet, but it's going to be pretty slow. Now, another normal thing that changes is mental flexibility. So as we get older, we try to solve new problems with old solutions, the solutions that have always worked for us in the past. But what happens when those old solutions don't solve the problem? We're less adept at being able to think outside the box. Again, the age group that is most mentally flexible are kids in their 20s and 30s. Another thing that happens is word-finding difficulties that are common in normal aging. So this is the tip of the tongue phenomena, the whatchamacallit phenomena. It happens to me all the time in the kitchen cooking with Michelle and need her to hand me that, you know, that thing with the handle in the drawer. The spatula? Yes, right. So don't be too concerned about changes in word finding if you've experienced that. And the memory changes of normal aging really have to do with like senior moments or golden moments where you're in the living room, you go into the kitchen, and then you walk into the kitchen and you think, now what did I come in here for? And then you go back to the living room and, oh, that's right, I was going to get a glass of water. So senior moment. So to that point, this is one of my favorite cartoons, Superman in his later years. Dang, now where was I going? Senior moment, normal aging. However, in normal aging, our independence in activities of daily living are completely preserved. So somebody can balance their checkbook, navigate to places they need to go. They don't have trouble organizing appointments and keeping track of them. They can live independently without support. Their memory is intact for current events and what's happening. And most importantly, they can pass the screening measures that we're going to teach you today. That is normal aging, people who can pass these tools that you'll be using. So how does normal aging then contrast with dementia and Alzheimer's disease? Well, first off, dementia is just a very generic term that describes a whole class of conditions that causes a decline in someone's memory and thinking that's severe enough that it interferes with their activities of daily life, balancing the checkbook, taking care of themselves. And we know that dementia is not normal aging. There is no senility or dementia that is normal. Now, briefly, I want to share with you some of the common signs and symptoms of a dementia, with the understanding that depending on the type of dementia and the individual person, a person may have some or all of these changes as the dementia progresses. Everyone's brain responds a little bit differently. You know, of course, that the hallmark symptom is memory loss. And typically in dementia, it is not long-term memory that's affected first, it's short-term memory. Why would it be that the memories for what you just did this morning, the breakfast you had, or the conversation you had yesterday, are more susceptible to fading away in dementia than what you did 40 years ago? Well, the answer, to oversimplify, is that memories are sort of stacked up on top of each other in the brain. And so your childhood memories and memories from your 20s and 30s are very, very deeply stored and embedded in the brain. And that means when there's something wrong happening in the brain, those memories are more protected for longer. But as the disease progresses, the disease penetrates deeper and deeper into the brain and gradually affects those old memories. But initially, it's short-term memory loss that you see. Of course, you know also that people with dementia and Alzheimer's disease lose track of time, so they may be telling you about something that really happened 2 years ago, but they're talking about it as if it happened a month or two ago. They have difficulty with speech. And I was telling a group yesterday on the Big Island about my empathy for people who, with dementia, are starting to lose words, because I went to a very small college in Minnesota called St. Olaf College, a little Lutheran school, and those Lutherans made us be proficient in a foreign language before we graduated. And so I took Spanish, and I was horrific. I was a very good student, but I was really bad at Spanish. But the final exam was very intimidating. The professor had a reputation for being very strict. And the final exam was that your name would be called. You'd come to the front of the class, and she would tear out a picture from a magazine that you'd never seen before, hand it to you, and for 10 to 15 minutes you had to, in Spanish, articulate what was happening on the page. Now, I about collapsed because I was so afraid. And the vocabulary that I had available to me was so small and primitive that the only things I could say were things like, this is yellow, this is green. And it was just awful. But when I think about the clients and patients that I've worked with who are losing language, I think back to that time and how scared and difficult it was for me to communicate. And this is what it's like for someone with dementia. They're losing vocabulary, they're having a harder time expressing themselves. And so if you don't have words to express what you're thinking and feeling, what do you have? You have behaviors. And so the behavioral problems that you think of associated with dementia really aren't problems as much as communication. It's the way that people are trying to express their needs. Of course, in dementia, you can also have diminished concentration. It may be someone early can focus on one thing, but not 2 or 3 things at a time. You can have changes in mood and personality, because mood and personality is also held in the brain. And so as the pathology moves around, those things are affected as well. Visuospatial problems, that's a fancy word for saying people get lost Your internal compass becomes damaged, and so you can no longer orient yourself to where you are or where things are. Over time, learning new things become very difficult. I will have families sometimes tell me after I've diagnosed their loved one with Alzheimer's disease, but Dr. Barclay, she can't have Alzheimer's disease. She's still playing bridge. Right. She's still playing bridge because she learned how to play bridge 50 years ago. And she's been playing every week since then. So that's a very deeply embedded skill. It's not new. If we tried to teach her a new game, then you would see that she would really falter with that. Problems with abstract reasoning, problem solving, and judgment. You see this as well. It's why older people with dementia are, of course, at a higher risk of being scammed financially and being taken advantage of. I mentioned earlier these behavioral communications, and so some of them are listed on the slide here. As dementia progresses, people can become anxious, depressed, withdraw. They can see and hear things that are not there, become more paranoid, have repetitive behaviors. Sundowning. What is sundowning? Sundowning is just a term that means that in the afternoon or early evening hours, people with dementia's brains become fatigued and overloaded, and they can be more confused and have more of these behaviors. And that's because when you have dementia, your brain is compromised and you can't take any longer a full day of activities. And so by the time lunchtime comes around, it's sort of like our midnight. You know, if you stayed up till midnight and had a full day, you would feel mentally fatigued. It just happens a little bit early in the context of dementia. I want to also recognize that sometimes when older adults become acutely confused, so they were okay last week, but this week they don't seem to be themselves, that typically is not a dementia. Dementia typically is much more gradual and slowly progressive. And so if there's an abrupt change, you think about some of these other things that I have listed on the screen. It is often a medication problem. So someone took too much of one thing or not enough of another, or there's a new medication on board that has medication side effects. Often a UTI, a urinary tract infection, causes delirium, acute confusion. We have no idea why a bladder infection goes right up to the brain, but it does and causes this delirium. People sometimes don't hydrate well. Dehydration can cause acute confusion, uncontrolled blood sugar, sleep deprivation, pain. All of these things are things that we can do something about. And so oftentimes if we recognize it, we can try to reverse the symptoms if possible. So what are the things that raise your risk and my risk of developing Alzheimer's disease or dementia in our lifetime? Well, by far and away, the #1 risk factor for all of us is age. It's all about age. So who here is not getting older? Okay, so we all share that risk factor in common. Now, some of these risk factors we can't change. Age is one of them, gender is another, our ethnicity, as we talked about. But there are some of these risk factors that we can do something about. And if you look at the lower left-hand corner, in particular, cerebrovascular issues, so controlling high blood pressure, high cholesterol, your weight, not smoking, avoiding a heart attack and stroke, all of those things increase the chances of developing a dementia. On the right-hand side, you see traumatic brain injury. People who have had a significant traumatic brain injury with a loss of consciousness for more than a half hour are at an increased risk of developing dementia later in their life as they get into their 70s and 80s. Low levels of education. People with a second-grade education are more prone to dementia than people who graduate from high school, go to college, or get a graduate degree. And that's because of something called cognitive reserve. The more you use your brain, the more connections develop that protect you later on from pathology. One risk factor not on this slide is a developmental disability. Conditions like Down syndrome also increase the chances of developing a dementia. And lastly, we'll talk more about this later, mild cognitive impairment is an early form of cognitive changes that if a person has that diagnosis, they're also more likely to get Alzheimer's disease or another dementia. But I just want to come back to age because this is where we are all at risk. If you look at this graph or table, you see that more than 80% of people with dementia are 75 and older. So increasingly likely as we age. So how is dementia diagnosed? Well, you've probably heard in the popular news outlets, magazines, and news shows about all these fancy brain scans and things that come out. But did you know that not a single one of them can by itself diagnose dementia or Alzheimer's? So we don't have a litmus test. We do not have a blood test. We don't have a brain scan. We don't have anything that says yes or no, this person has Alzheimer's disease. Instead, what doctors do is a bunch of assessments to rule out other possible causes. But if we do all of these things and there is no medical explanation for why someone is having significant cognitive impairment, by default, it is dementia, and it's likely to be Alzheimer's disease. Now, you can imagine healthcare providers don't like this very much. They would much prefer to have a yes or no, right? So that's part of the challenge on their side. But if someone is sent to the doctor for a memory loss workup, what's going to happen? They're going to get a regular physical exam and something called a neurological exam, which is simply just checking reflexes and looking for signs of how the central nervous system is functioning. They're going to do an objective cognitive assessment, like the type that we're going to teach you this morning. They're going to take blood, not to detect Alzheimer's disease, but to rule out vitamin and nutritional deficiencies, thyroid problems, low vitamin D or B12, other things that can cause memory loss. They may do a brain scan. What's the point of a brain scan? In most cases, you don't see Alzheimer's disease. All you do is rule out strokes, swelling of the brain, brain masses, other explanations. Of course, if someone lives in Honolulu, as opposed to in rural areas, you may have access to occupational therapy, physical therapy, so these folks may be brought in as well to do an assessment. But again, dementia, Alzheimer's disease, a diagnosis of ruling everything else out first. So to that point, I want to mention that when we do a workup, sometimes we're really pleasantly surprised because we turn up something that can be resolved. So sometimes people have a mental health condition, depression, that is looking like dementia. But if we treat the depression, they improve, their memory loss improves. Alcohol and substance abuse can sometimes look like dementia. Medication side effects and vitamin and nutritional deficiencies, as I mentioned earlier. So what I've spoken about so far is this generic term dementia, but what is the difference between dementia and Alzheimer's disease? And by the way, I should have told you at the start that the doors in the back are going to be locked and no one is leaving this room unless you can answer this question today. Okay, this is just basic. You must know the answer to this question because families will ask you this all the time. What is the difference between dementia and Alzheimer's disease? Well, dementia is certainly just a generic umbrella term. All dementia means is there's something going on in the brain, but you don't know what, causing a decline in thinking and memory that is severe enough to interfere with everyday life. You see in the slide here that there are many causes of dementia, including Alzheimer's disease, but many of these others as well. And I'm going to briefly touch on 4 of the most common this morning. This slide just shows you some other examples of dementia. There are over 100 causes of dementia. What you see in red is Alzheimer's disease, and that's because Alzheimer's disease is the most common form of dementia. But you can have dementia from a stroke, or Parkinson's disease, HIV/AIDS, MS, from a brain tumor, from pickling your brain from alcoholism. That's called Wernicke-Korsakoff syndrome on the lower right. Swelling of the brain, normal pressure hydrocephalus. Chronic hypoxia, that means lack of oxygen to the brain for a period of time. Creutzfeldt-Jakob disease or mad cow disease. All of these are examples of conditions that cause dementia. With that, though, I want to have you focus on this pie graph because what it shows is that most dementias are due to Alzheimer's disease. In fact, if you worked with 100 clients who had dementia as their diagnosis and you guessed that all of them had Alzheimer's disease, you would be right 3 out of 4 times, 75% of the time. The second most common form of dementia is called Lewy body dementia. How many of you have heard of Lewy body dementia? So a handful of you. Lewy body dementia is on the Parkinson's spectrum. So people with Lewy body dementia have all the cognitive problems of Alzheimer's, but also movement problems. So they have tremors and falls and difficulty with motor skills. The third most common form of dementia is vascular dementia. That name is a little more obvious. Vascular meaning the vasculature, the blood vessels in the body, in the brain. Vascular dementia is from strokes or a breakdown in the small blood vessels in the brain. We'll talk more about that later. Lastly, FTD, or frontotemporal dementia, probably one of the most devastating forms of dementia because instead of affecting memory, it affects personality and mood. And so these are folks who, as they get into their 50s and 60s, become behaviorally abnormal. They're blurting out rude comments, becoming sexually inappropriate, taking risky behaviors that they never took before, very, very hard on families. And so we'll come back to some of these a little bit later. When Michelle and I do training for doctors and healthcare providers, we're trying to help them understand that dementia is not an appropriate diagnosis. We need families and people to get a more specific name for what they're dealing with so that they can get appropriate resources and treatment. And so dementia, senile dementia, senility, hardening of the arteries, brain disorder, memory loss, none of these really should be used, but you see them all the time, don't you? This is very common. So I want to share with you a little bit more information about Alzheimer's disease, and specifically, just real quickly, I want to give you some information about what is actually happening inside the brain, and so that you have enough information to make you dangerous when you're out working with some of your clients. So I'm going to show you this cartoon video and then talk a little bit more about the pathology moving about the brain.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination, and in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure.
So I like that video because in a few minutes it just shows you visually a little bit in a simplified way about the pathology moving around in the brain. And so I want to explain a little bit more about what you heard. So Alzheimer's disease, a slowly progressive degenerative brain disorder, degenerative meaning that over time there's deterioration, loss, death of brain cells. There's a steady decline in thinking and memory, again, severe enough to interfere with everyday life. And there are specific chemical and structural changes that are happening in the brain because of this pathology. Now, as of today, there is no cure. There's nothing that can be done to reverse the symptoms. And unfortunately, you may know a little bit about the medication that is used sometimes to treat Alzheimer's disease or other dementias, things like donepezil or Aricept. What do these drugs do? Well, for some patients or clients, they help to reduce the impact of the symptoms for some time. Basically, what they're doing in the brain is increasing a memory that a chemical that the brain needs to form memories. But these drugs do not stop the brain pathology. There is nothing that stops the pathology from keeping accumulating. All the drugs do for now is slow the expression of symptoms for some people. Researchers don't exactly know what causes or triggers the start of Alzheimer's disease, but most experts agree that there's probably more than one cause, more than one trigger that comes together to catapult the disease. Now, I'd like to explain in accessible terms what plaques and tangles are and what's happening in the brain in Alzheimer's. So you've heard about amyloid plaques. What is an amyloid plaque? Well, amyloid is a protein that all of us in the room have in our bodies and brains today. Amyloid is a normal protein in the body. What is a protein? You can think of a protein like this lei or a pearl necklace. A protein is simply a very large string of smaller pieces called amino acids. And so it's a big, big, long string of stuff. Now, when you were eating breakfast this morning, your food went into your stomach, into your gut, and what is your gut doing while you're sitting here? It's digesting your food, or metabolizing. And what does digesting mean? Digesting just means cutting up big stuff into smaller and smaller pieces so that your body can use them. Well, the same thing happens in the brain. The brain is cutting large proteins to make them more manageable and usable. So, for reasons that we do not understand, in Alzheimer's disease, the brain accidentally cuts this amyloid protein in the wrong place. And what happens when your brain cuts a protein in the wrong place? All of a sudden, you've got two pieces that the brain no longer recognizes. They're not the right size and shape anymore. And so the brain characterizes these as foreign bodies. So what does the brain want to do with foreign bodies? This is bad stuff. What do you want to do with bad stuff in the brain? Yell out. Get rid of it. Thank you. So the irony is that you have something in your body called the blood-brain barrier. The blood-brain barrier is a thick netting that prevents things in your body that are toxic from getting up into the brain. However, in Alzheimer's disease, ironically, this blood-brain barrier prevents these foreign bodies from leaving the brain. They can't get through the gates. So what's the next best thing to do with foreign bodies floating around in the brain if you can't get rid of them or flush them out? Contain them. So what the brain tries to do first is gather them all up. So these are like piles of trash heaps. The brain wants to put them all together and set them over here. But then over time, a few months later, there are more. And so we're gathering them up again and setting them over here. Now, on your commute this morning from home to this training, you were in your car, probably, or public transportation. And what would happen if you came across a construction zone with a roadblock? Presumably, there would be a detour to get around that roadblock. It may take you a few extra minutes to get where you were going, but you would still get here. In Alzheimer's disease, when someone has a few of these plaque heaps, trash heaps, like a detour or a roadblock, the brain cells are still able to communicate. It just takes a little bit more time because they have to go kind of a different route. But as the disease progresses, more and more and more and more of these roadblocks start to develop. And eventually, the cells are totally boxed in, and they have no way to communicate with each other. So this is what is causing the memory loss and the thinking problems of Alzheimer's disease. So these piles of trash are just amyloid plaques. Now, as these plaques accumulate in number, the brain cells nearby die. And when a brain cell dies, it releases everything inside out into the brain. And so all of these little chutes and ladders and structural pieces are just free-floating. And what happens when these things are free-floating? They get all tangled up with each other. And so the neurofibrillary tangles are just this tangled up stuff from inside the cell, causing more damage, more cell death. So this is just a quick snapshot of actually what is happening in the brain. Typically, this pathology starts in the memory center, which is above your ears, and then moves gradually forward. What we know from recent research is that by the time a person ever shows any signs or symptoms whatsoever of memory loss, their brain has been accumulating these plaques and tangles for 10 to 20 years. 1 to 2 decades. Which tells you something about the brain, which is that it's pretty freaking miraculous that you can take 20 years of pathology and your brain is still able to compensate. But at a certain point, we all have a threshold. We all have a limit. And when we reach that limit, we start to show signs and symptoms. So on the screen here is just a picture, to put this in visual terms, about an older adult's brain. On the left is a 75-year-old normal-sized brain. On the right is one with Alzheimer's disease. So what do you notice? It's quite a bit smaller, and that's related to all the cellular death that has happened. Now, this is another view of the brain. This is as though I am looking at you from the slide, but my face is removed. And so the top is the top of my head, the right's the left side of my brain. What you see in the top is that that's a normal brain. So those little spaces in the middle are fluid-filled ventricles. We all have that. At the bottom, you see those huge spaces. And that's because of all the death of the neurons, the brain cells. And so the inner part of the brain the space starts to grow and grow and grow. So that's to put it in a visual perspective. So I want to share with you also a little bit of information about staging of Alzheimer's disease. As people with the disease progress, what does the stages look like? First, what I want you to know is that there is no agreed upon tool or staging sort of structure that everyone in healthcare uses. So by default, we simply talk about early, middle, and late stage Alzheimer's. And so I want to share with you what, generally speaking, early, middle, and late stage looks like, with the understanding that, again, everybody is a little bit different and progresses through these stages in unique ways. So a person can be in early stage Alzheimer's disease for 1 to 4 or more years. These time frames are just very loose and averages. So what happens in early stage Alzheimer's disease? Well, for most, they're having short-term memory loss, but they're still able to compensate and cover most of the time. They may lose track of appointments. They may write themselves reminders, but they're not writing enough context. And so when they come back to the reminder, it isn't jogging their memory as effectively, or they're losing their notes because they're becoming less organized. They might show up for an appointment on the wrong time or day. They know they have an appointment, they're just losing track of time. They have more difficulty multitasking. So someone in the early stages of Alzheimer's may be able to focus on one thing at a time, but if there's a distraction, the telephone rings in the middle of cooking, they may fully orient toward the phone call and then forget about the pot on the stove. They have more trouble planning and solving problems. They have more difficulty finding words and speaking. And they may be withdrawing socially. Why would people with beginning Alzheimer's disease start to pull away from family and friends or not want to go to social gatherings as frequently? Well, for one thing, for a lot of people, it's embarrassment. Because if you were losing words losing memory, it would be very uncomfortable to put yourself in a social situation where you could see people that you knew, but you may not be able to come up with their names, may not be able to know what you said to them last week. And so there's a natural tendency to start to withdraw. That withdrawal is not good for the brain. And so as you hear about some of the resources later, it's important that we connect people and try to encourage them and support them in getting out and more connected to other people. And again, in the early stages, people can be depressed, people who never had depression before, or become more anxious, who were never anxious before, because of what's happening in the brain. Now, one thing you may notice is not on this list, and that is behaviors. In true early stage Alzheimer's disease, for most people, there is not sundowning, there is not wandering, there are no hallucinations or delusions. Those behaviors are characteristic of mid-stage. In fact, in true early stage Alzheimer's disease, if someone is really detected early, you probably would be hard-pressed to know that they were impaired in a conversation with them. Just like Wendy Mitchell in the video, articulate person, still covering for some of the underlying deficits. So middle stage Alzheimer's disease, what does that look like? It can last anywhere from 2 years to a decade or more. And this is the stage at which people are really having more difficulty with time relationships and knowing where they are and where they're going. They're having less insight about the problem, thankfully. So often in the beginning, people are aware of the memory and cognitive changes. But in the middle, they start to lose that awareness, which is a good thing. Learning new things becomes very, very difficult. And they start losing memory for first acquaintances, and then distant relatives, and then closer and closer relatives. Now, my grandmother passed away a few years ago at the age of 96 with mid-stage Alzheimer's disease. And until almost the end, my grandmother remembered who I was. But she often was confused about who my sister was. My sister is 3.5 years younger. That's very typical because I am an older memory in her brain. And so my name and who I was, my face, was more preserved than my sister's. I also think there were other reasons my grandma remembered me more than my sister, but I won't get into that. So that's very common. If someone with dementia has 7 children, it's the first and second born that they're going to remember longer than typically the more recent kids. You can have more pronounced mood and behavior problems as the disease progresses into mid-stage. These folks are really starting to struggle to be at home independently without support. And the disease is attacking basic functions that are messing up their circadian rhythms. And so people are sometimes awake at night and sleepy during the day, which is really hard for family members. They can start wandering, have delusions and hallucinations, and again, more of the behaviors that you know about in Alzheimer's disease start to occur here. Now, in late stage or end stage disease, this is typically 1 to 3 years. Can be longer, but typically this is a little bit of a shorter phase. And in late stage Alzheimer's disease, there is real severe disorientation to time and place. And so people may not even know their own name or where they are. They have no short-term memory ability whatsoever. They typically only have a few words or no speech at all. They are bedbound because they've lost the ability to control their legs and motor movements. They lose bladder and bowel control. They no longer recognize family members and really are not able to survive without total care. So a very sad and sort of depressing ending to the disease. Very hard at this point for family members to keep someone at home when they are this impaired and in that need of support. So that is just to make sure we're all on solid footing with what early, middle, and late generally looks like. What I want to do for a few minutes to conclude, just sort of making sure we're all on the same page before we move on to more exciting stuff, is tell you a little bit of information about some of these other conditions and diagnoses that you might hear something about, so that you're a little bit familiar and you understand that it's not all Alzheimer's disease. I mentioned earlier mild cognitive impairment, or MCI. How many of you have seen that diagnosis before? Okay, so some of you. MCI is a relatively new term. So in the past, all we had was normal and dementia. You either were healthy, brain aging, or completely demented. Very extreme states, right? And so clinicians and researchers a number of years ago started saying, you know, I wonder if there isn't some transitionary middle stage between normal and demented. We could call it something and maybe treat these people a little bit earlier and track them over time to determine how they progress. And so they developed this term called mild cognitive impairment. And so you see here, instead of normal and demented, now we have normal, mild cognitive impairment that comes before dementia. So what is MCI? What does that look like? Well, someone with mild cognitive impairment is having symptoms of memory loss and thinking changes. And they are having enough symptoms that can be detected on the tools that we're going to teach you to use this morning. So we can detect that they are starting to have changes in memory and thinking. However, these changes are very early and mild cognitive impairment. And they're not severe enough to really impact someone's ability to stay at home. So someone, for example, can still mow the lawn or vacuum or prepare a meal, but they may need some prompting to get started or a reminder or two in the middle to stay on track. And so again, they have mild issues, but not enough to really impact daily life. What happens, though, if you follow people with this diagnosis, mild cognitive impairment, over 5 years or more, what you see is that more than half of them go on to develop Alzheimer's disease or another dementia. So the majority of people with MCI go on to develop dementia. You may ask yourself, well, what about the other half who never develop Alzheimer's disease or dementia? What's up with that? How could someone have mild cognitive impairment that doesn't decline? Any guesses? You're so quiet. No one has a guess? What's that? They died? Well, sure, if you die, then that's going to stop the progression to Alzheimer's disease. That's one way to do it. What about a less dramatic outcome? Well, clearly, these people who are not progressing have some other cause of their cognitive impairment that is not progressive or degenerative. For example, in my clinic, we see a lot of people with severe sleep apnea, and that apnea is not treated. And sleep apnea that is not treated is associated with premature cognitive problems with age. And so these are people who we can detect they are having some thinking problems, but they plateau, they stay the same. They don't significantly change or progress to Alzheimer's disease. Or maybe someone with MCI has, unbeknownst to us, a vitamin or nutritional deficiency or depression or a mental health condition that we didn't detect before. So there's something else causing the mild cognitive impairment. Make sense? But the takeaway message is most people with an MCI diagnosis do eventually develop Alzheimer's disease and dementia. It's just a transitionary phase on that way. So I want to say a few words also about young onset Alzheimer's disease. Again, Wendy Mitchell. Wendy is somebody who was diagnosed with Alzheimer's disease at an early age. And so what is young onset? Well, young onset Alzheimer's disease is the same disease. It's the same plaques and tangles and cellular death and same pathology happening in the brain as regular Alzheimer's disease. The only difference is that it starts before the age of 65. Now, this 65 cutoff is very scientific. No. Why do we have this arbitrary 65? So if you're 64 and a half and develop Alzheimer's disease, then it's young onset. But if you just turned 65 yesterday, it's just Alzheimer's disease. Does that sound very medically sound? No. Why 65? Because it's just in our minds that that's Medicare eligibility. It's what we talk about as an older person. That's the only reason for it. So Alzheimer's disease with young onset just happens when people are younger than 65. Unfortunately, it can often strike in people's 50s, their 40s, their 30s. There are some very rare cases of people in their late 20s as well. What you should know, though, is that young onset Alzheimer's is not common. So it only accounts for 5% of all Alzheimer's disease. Now, I will offer just a word of caution, which is that some people refer to young onset as early onset Alzheimer's. But that is very confusing. Early onset, some people confuse that with early stage Alzheimer's. Now, if you're 75 and have Alzheimer's, you can have early stage. You can be in the early stages, or you can be in the late stages. If you're 55 and have Alzheimer's disease, you can also be in early stage or late stage. So that's why we talk about this as young onset, not early onset. Some of you may be wondering if there's a genetic component to young onset. I want to back up a minute and talk about the genetics of regular Alzheimer's disease that affects older people. Is there a genetic component to that? Yes, but it is very small compared to age, the risk factor of age. Most people with young onset Alzheimer's disease have just what they call sporadic occurrence. There is no genetic contribution that we know of. It's only a very small percentage of people with young onset. So of the 5% of people with Alzheimer's disease who have young onset, younger than 65, 13% of them have these genes called deterministic genes. If you have a deterministic gene, it means that with 100% certainty, you're going to develop Alzheimer's disease. And so you may have seen some of these families where one by one, they all get the disease. When I was at UCLA in training, we were working with a family from Mexico that had immigrated to Los Angeles. And they were 6 siblings, and they were all getting Alzheimer's disease as they turned about mid-30s, 35. Very, very devastating. So as you can imagine, Alzheimer's disease brings a lot of challenges no matter what age you are. But if you're younger, your 40s, your 50s, there's a whole heck of a lot of other challenges that are very devastating. For one, these folks often have children at home that they're raising or in college. They're unable to work because their brain is failing them, and so they often lose their health insurance and their income, and so they have a lot of financial strain. They have a difficult time getting a diagnosis because guess what? Alzheimer's disease is not the first thing that a doctor is going to think about when you're 40 years old. So they can go for years and struggle to get an accurate diagnosis. In fact, one of my favorite patients, who I eventually diagnosed with young onset Alzheimer's disease, had been told by countless doctors that she was depressed, stressed at work, menopausal. There were all these explanations for her memory problems that were eventually we knew inaccurate. So lots of unique challenges there. So Lewy body dementia, I mentioned as the second most common form of dementia. And Lewy body dementia, again, is on the Parkinson's spectrum. And so Lewy body dementia affects up to 25% of cases. That's probably a generous estimate. I think most statistics are a little bit less than that. But you can imagine if Alzheimer's disease is so rarely diagnosed, Lewy body dementia is really often misdiagnosed and not called out. And when it is diagnosed, it's often misdiagnosed as Alzheimer's disease or Parkinson's disease. So the hallmark symptoms, again, are memory loss, thinking changes like you see in Alzheimer's disease, but with all of these motor problems. Now, in Parkinson's disease, you can also have dementia. You can have a Parkinson's disease dementia, but it looks like this. In Parkinson's disease, for years, someone has a tremor and motor stiffness, and maybe 10, 20 years later, they develop cognitive problems. But in Lewy body dementia, the motor problems and the cognitive problems start within about a year of each other. So both are kind of starting simultaneously. That's the difference. Also in Lewy body dementia, what you see is that people have very early visual hallucinations. So are hallucinations fairly common in Alzheimer's disease? Yes, but not until mid to later stage. In Lewy body dementia, you have the cognitive problems, the motor problems, and these visual hallucinations right up front. I'll tell you that these visual hallucinations, the brain is a funny thing. They're typically of two varieties. And so if you ever hear someone describing these two things, you'll be a red flag in your mind about possible Lewy body dementia. One is that these people often describe small furry animals running around, the size of mice or cats, in the kitchen cabinets, under the furniture. The second type is they often describe people, sometimes families of people, who are in their home, so unwelcome guests. They will say things like, I try to tell them to leave and they don't respond to me because they're not there, right? Often in Lewy body dementia, the clients, the patients are not afraid of these animals or people, but they're more frustrated and annoyed. After all, this is my house, dang it. Why are all these people in it? I can't get rid of them. So those are very hallmark signs. It's also common for people with Lewy body dementia to act out their dreams. And so the spouse will say, I can't sleep in the same bed anymore because he's thrashing and yelling and moving his limbs around, hitting me, enacting his dreams. That's characteristic of this condition. Now, I talked about in Alzheimer's disease these plaques and tangles in the brain. But in Lewy body disease, Lewy body dementia, there's another pathology happening that is different. And wait for it, the pathology is called Lewy bodies. So that's where the name comes from. It's just a different type of pathology that again kind of accumulates and causes these motor and thinking problems. The course of dementia with Lewy bodies is a little bit faster, probably because we're not very good at detecting it early. And so after a diagnosis, people are typically living about 5 to 7 or 8 years. But it varies a tremendous amount. Vascular dementia, I mentioned earlier that this is the third most common form of dementia, less than 10% of people. We used to think vascular dementia was very common, but what we know today is that the vast majority of people with vascular dementia also have Alzheimer's disease. And that's because breakdown in the blood vessels of the brain are a risk factor for Alzheimer's disease. So little strokes can kick off the Alzheimer's process. So often it's called a mixed dementia. Now, the truth is that if I had invited today someone with Alzheimer's disease and vascular dementia on the stage to talk with you, you probably would not be able to discern the difference between them. So the symptoms look very similar. They overlap with Alzheimer's disease. Of course, when someone has a major stroke that causes an abrupt change in their thinking and memory, then that's a tip-off that it may be a vascular dementia and not an Alzheimer's disease. But you can also have vascular dementia from breakdown of the really, really small blood vessels in the brain, the capillaries in the brain. And if it accumulates enough, you can have a dementia because of that. Vascular dementia, the course of vascular dementia can be even longer than Alzheimer's disease. So people can live with that condition for many, many, many years. Lastly, I just want to share with you a little bit about frontotemporal dementia. Again, this is a rare condition, but it's probably the fourth most common form of dementia, affects less than 5% of people. And remember I said Alzheimer's disease starts in the memory center of the brain, which is above your ears, and goes forward. But frontotemporal dementia starts in the front of the brain and moves back. What is right here behind my index finger in the front part of my brain? What's right here is my personality, control of my mood, control of my impulses, and my disposition about my life and relationships. And so in frontotemporal dementia, what you see is these folks are often misdiagnosed as having a psychiatric condition. Because they don't have memory loss in the beginning, they have mood and behavior problems. They look psychiatric. So here's some of the hallmark symptoms: changes in emotions, behavior, and personality. As I said earlier, they lose their filter. So as I am speaking up here, you're listening to my voice, you're looking at me, probably thinking different things about what I'm wearing or what I look like, all positive, I'm sure. But you're not blurting them out, right? Because you have an appropriate filter. So we all have these thoughts that we don't say, but someone with frontotemporal dementia doesn't have that filter anymore and is just sort of saying what comes to mind. They are disregarding social norms, and so they may be sexually inappropriate, patting people on the behind or saying sexually explicit things that are not appropriate in our culture. They don't have as much empathy for other people. They don't understand the trials and tribulations of others because it's all self-focused, me, 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 me. They can become more obsessive compulsive, particularly around oral things and sweet and soft foods. And so I have a client who I saw a few weeks ago who is eating bags of marshmallows because it's soft and sweet, and ice cream. So you see that a lot. Unfortunately, these individuals lose and don't have any, actually, insight about their condition because insight and self-awareness is also in the front. And so these people are really hard to treat because they don't believe they have a problem and they don't accept medication or treatment. And so families really, really struggle. I was telling another group on the Big Island that one of the saddest cases that I ever saw was a gentleman, an engineer, who was in his late 50s, had a family, 2 kids. His wife came home one day and he was standing at the kitchen island with a laptop computer watching pornography. Now, as you can imagine, the wife was a little taken aback by this. This was not typical. But to her surprise, he had very little of a reaction and continued to do what he was doing, even despite her reprimanding and yelling at him. He also had 2 teenage kids in the room next door. Now, she didn't know what to make of this, but this behavior continued. And he eventually withdrew $10,000 from their bank account. When confronted about this, he told his wife that, very matter-of-factly, well, on one of these websites there was a Malaysian woman who told me that she was being held as a sex slave and needed $10,000 to be freed. And so I sent her the money. Well, wouldn't you know that $10,000 didn't quite cut it, because then he was asked for 20 and then more. You know, this is a financial scam, of course. And this went on, and she had a difficult time closing down the bank accounts and getting his name off of them, because when he would present himself to the bank, he could talk himself through everything logically, wasn't having memory loss, seemed okay. But he was hospitalized psychiatrically 5 times over years. And eventually, the 6th hospitalization, there was a neurologist who was rounding who said, wait a minute, this person does not have bipolar disorder or whatever the psychiatric diagnosis was. This is frontotemporal dementia. And so he eventually was able to get a diagnosis and care. But that's a typical course for a lot of these people, misdiagnosed. What you see at the bottom is that there's also a different type of FTD that doesn't affect behavior and personality, but language. Language is also in a front part of the brain, and so these people have a lot of difficulty with word finding, much more so than other people with Alzheimer's disease. So, as you can imagine, people with frontotemporal dementia have a lot of challenges, just like the young onset Alzheimer's disease folks. It takes a heavy toll on their family relationships. There's a lot of distress and discord. These people are sometimes getting divorced because they don't have a diagnosis and are really struggling. They get into financial and legal trouble, and there's not a lot of services that are very appropriate for someone with frontotemporal dementia because they're physically and medically okay. In fact, I knew someone with FTD who was put in an assisted living who scaled the 8-foot wall and ran away because he was strong enough to get out of the confines of that environment. So as we wind down this first just sort of basic knowledge set, I want to talk with you and highlight a little bit about why early detection is so important. Why do we care about moving the needle from where it is today, mid to late stage, to earlier? And to do that, I want to show you just another quick video here.
I just didn't know what to do. I went up the escalator, I went down the escalator, I stood in the middle of the airport. And at that point, I felt like I was going to cry. I mean, it was just such an uncertain feeling. was enough to say, okay, there is a problem. And I had said to my doctor about a year before that I did have memory problems and he and I needed to talk. But, you know, you just sort of put the things off. He took a piece of paper off his pad and said, well, here, just draw a clock and make it whatever time he had suggested. And I didn't do it right. Shock of my life. You know, I look at myself in the mirror and there's nothing wrong physically. It's in the brain. Some outright disputed the diagnosis and said the doctor was wrong. You say to the person that you have Alzheimer's and they go through the list of stereotypes. Well, you can't have it because you're too young, or you can't have it because, in fact, we're able to communicate. The earlier a person is diagnosed, you are able to put your own affairs in order. You're able to, and that's like your banking and representation agreements and, you know, your legal affairs, your financial affairs. But you're also able to learn about your own health, so that you don't, once you're diagnosed, you don't sit at home and sort of think that's the end of it. It's been 3 years for me, and I have kept active. And the longer you ignore it, the harder it is, the harder it's going to be. The early diagnosis will make sure that family and friends understand why you are, you know, repeating the same question. She's been very understanding, very helpful, very comforting. It's very comforting. Now when I go through airports, I arrive early and it's all very, very calm. It's a process, but it's all very, very measured. The earlier you confront it together, the more you're able to wow.
The first thing I want to tell you about earlier detection is that most people want to know if they have Alzheimer's disease. Now, this has been researched up one side and down the other by Harvard and many institutions around the country, and the results always say the same thing, which is that 80% or more people in the US, when asked, if you had a brain disease like Alzheimer's disease, would you want to be told? And the vast majority say yes, they do. They would want to be told. Now, is this 100% of people? No. You're always going to find people who don't want to know, right? They're living in the moment. They don't care about this. They don't want to think about it or do anything about it. And the truth is that person-centered care is about telling people, giving people information, empowering them, and then it's up to them to decide whether they are going to make use of that information, follow our recommendations, or not. But I want you to know that the vast majority of people say they do want to know. Why is earlier detection so important? Well, as I mentioned earlier, it's not all Alzheimer's disease. That sometimes we can uncover another medical condition, an infection, a mental health problem, and can do something about it, a vitamin or nutritional deficiency, and improve their thinking. We can also allow people to understand the symptoms and how to manage them. So again, if you don't know what you're dealing with or what to expect tomorrow or next year, you don't really have any other tools except in the moment. And so giving people a name and resources helps them to be more mindful about options. You can start treatment sooner and make decisions about the future. Now, I want to share with you that I used to work exclusively in the hospital. And every day, every Monday morning, I would come in and I would get the census, the number of patients, and I would talk to the social worker and the nurses. And every week, the social workers would tell me the same thing, which is they would give me a list of people with undiagnosed dementia who were in the hospital because they had forgotten to drink, were dehydrated. They were mismanaging their medications, so they had a medication interaction. They weren't taking care of themselves. They were failure to thrive. And so the staff would rehydrate them and get their acute medical condition fixed. But then the social worker would come to me and say this, Dr. Barkley, this person cannot go home. They're not safe. They're demented. And so then I would say, well, where is this patient going to go then if they can't go home? What do you think the answer was? Well, in Minnesota, the social workers called it the open bed. The open bed. The open bed in the skilled nursing facility, whoever had an opening, right? So I don't know about you, but I don't ever want to find myself or a loved one moving toward the open bed, okay? I want to be in a position where I can plan ahead about where I go, who takes care of me, have some ability to be part of the decision making. If a person isn't diagnosed with Alzheimer's disease until mid to late stage, we have completely robbed them, completely taken away their ability to be part of decision making about their future. And so one of the best incentives for all of us to recognize these conditions early is for person-centered care, to give people information to be part of their decision-making. People can build a support system. Michelle is going to talk about later about how important a team approach, a village, to support somebody with dementia, how much that can help people. And of course, having a diagnosis early gives family and friends the opportunity to know what to expect and to help and to avoid a crisis. If you're in a community agency and you're working with people with dementia, you know that most of the people who are really in need of help are in a crisis. And again, that's not the best time to intervene. So as we wrap up some of this foundation, I'm just going to ask you a little bit of quiz questions. And do not look down. If you're looking down, you're cheating. Don't look down at the answer. So question 1, what is the greatest risk factor for Alzheimer's disease? Number 1, A, family history and genetics, B, diabetes, C, age, and D, head injury. C. It's a mistake. It's not diabetes. We've moved that arrow at every training, but for some reason it really likes diabetes. So ignore that. Diabetes is not the number 1 risk factor. The number 1 risk factor is age. You got it. Alzheimer's disease is most commonly diagnosed today at what stage? Mild cognitive impairment, early stage Alzheimer's disease, C, moderate to late stage Alzheimer's, or D, late or end stage Alzheimer's? C, that's right. We are diagnosing today typically moderate to late stage, C. What percentage of people with Alzheimer's or dementia are told about their diagnosis? So how many cases of Alzheimer's disease are actually diagnosed? Is it A, 33, B, 45, C, 78%, or D, 90%? B, 45%, less than half of the time. Now, together, in the next segment, you and I are going to increase that percentage one by one client at a time, through the tools that we're going to teach you to use. I think that before we take a break, we have a few minutes, and so I want to open up for the next 6 to 7 minutes for you to be able to ask any question you want about the material we've covered so far: dementia, Alzheimer's disease, signs, symptoms, risk factors, stages, some of these atypical dementias. Can someone help with the microphones that we have down up on stage? Don't be bashful, because I'm going to stand here looking at you for 7 minutes. So who has a question? There are no dumb questions. And if you have a question, the chances are other people are wondering the same thing. Come on, it only takes one, and then everyone will be more comfortable.
I have a question for the audience. Can people hear me? I know you have to repeat it.
Sure.
If I diagnosed you with Alzheimer's disease right now, would you do something differently in the next year than you were planning?
So the question is, if you were diagnosed with Alzheimer's disease today, would you do something, anything differently in the next year? By a show of hands, how many would do something differently? So again, person-centered care. Not everyone raised their hand, which is okay, but the majority of you did, suggesting that you would take action of some kind. Maybe you'd eat your favorite cheeseburgers every day. That would be on my list. Or you'd take a trip somewhere, or you would plan ahead, communicate with your family, get resources and support. You'd do something. Yes?
Why does it start in the hippocampus?
Why does the disease start in the hippocampus? The hippocampus being, again, the memory center of the brain. Anybody have any guesses about that? Why would the disease start there? The answer is very simple. Nobody knows. I wish I could answer that question, but we don't know. That's part of the mystery of the disease.
How do you differentiate when there's multiple diagnoses like cerebral palsy, Parkinson's, and dementia? How do you determine what the root cause of the issue is?
So the question is, how do you differentiate between all of these different dementias, Alzheimer's disease, supranuclear palsy, some of these atypical conditions? The thing is that what that really requires, oftentimes, is a medical workup that may involve a primary care physician or a family physician, but in some of the rarer conditions that you just mentioned, it often needs to involve a neurologist, a neuropsychologist, because what we do is, for example, the brain testing that I do, when I sit with someone for 2 hours, at the end of that session, I have hundreds of data points, hundreds of metrics, detailed measurements about how different parts of the brain are working. And what that gives me is a particular signature in the data. And there's a particular signature for supranuclear palsy, cortical basal degeneration, Alzheimer's disease, Creutzfeldt-Jakob disease. And so we use that data in combination with the labs and the brain scans and things like that, because when you have all of that data, it converges and tells you a very good story. Now, is it true that you have to have an autopsy before you are 100% certain about a dementia diagnosis, to be able to call it dementia with Lewy bodies or Alzheimer's disease? Yes, technically speaking, you do still need to have an autopsy. However, in practical terms, we are very good now, if we do the right workup, at being very accurate in our detection and our diagnoses of a dementia condition, even the atypical ones.
So there's usually a period of observation before you can determine all the signals in the brain, right? That's not always evident in the brain scans early on, is that true?
Yeah, so the question is, there's often a wait period where you have to sort of follow people because in the beginning, these things may not always be evident on a brain scan or things like that. And it depends on the form of dementia, but oftentimes, the vast majority of dementias, the brain scans do not ever show you very much. They're just ruling out other stuff. What is much more telling is the neurological exam, the cognitive testing data, all of this other stuff that we're collecting. Yeah.
Dr. Alec, is there any relationship to what we normally would refer to as bad memory to dementia?
Can you say that again? Is there any relationship between what you would refer to as what?
Bad memory to dementia.
Bad memory? What do you mean by bad memory?
People always refer to it as I have a bad memory, I forgot.
Well, like math skills, spelling ability, we all are born and after our education come out with strengths and weaknesses. For example, I am a terrible speller and have no sense of direction. Either does Michelle, by the way. And so when we're looking around, we'll go into a store, look around, and then invariably go right back where we were before, even though we had intended to go a different way. So for me, I've always had a photographic memory. When I was in training, I could, on the test, visualize where on the page the information was, which really helped me for the test. But then a month later or a week later, it was gone. I had no ability to retain it. So everyone does have strengths and weaknesses. The truth is, though, that a lot of people blame real, serious memory issues on just, I've always had a bad memory. So I take that with a grain of salt. I don't really pay too much attention to it. What I pay attention to is how people do, how they perform on these screening tests that we're going to show you next. Yeah. Good questions. What else is on your mind? We've got 60 seconds. Yeah, so that's a good question. So frontotemporal dementia that causes all those behaviors, often misdiagnosed as a psychiatric condition. The question is, could psychiatric drugs then help to manage those symptoms? The answer is yes. That for the vast majority of those folks, there are medications that can control the mood problems that they're having, the highs and the lows. It doesn't completely treat the symptoms, but the real issue is that people with FTD typically refuse to take the meds. So even if we have supports that could help them a little bit, they're reluctant to take it. It would be like me trying to force you to take a pile of pills when you were adamant there's absolutely nothing wrong with me. Why should I do that? So that's a big challenge. But yes, there are medications that can help. Okay, yes, one more question. And so the question is, say someone is diagnosed in mid-stage with Alzheimer's disease or another dementia. Can they do anything to prevent it from getting worse? Well, what we know today is that the answer is generally no. That they can do things to minimize the impact of their symptoms. So in that way, they can make it less impactful for a period of time. But they cannot do anything today to stop the brain pathology. What can people do in early to mid stages with Alzheimer's disease to live better? Well, there's a couple of things. One is moving their body as much as possible. So exercise. We know that exercise sends signals to the brain to keep the brain cells healthy. In fact, a nurse at the University of Minnesota got a $5 million grant a number of years ago to study exercise as a treatment for Alzheimer's disease. Those results will be coming out in the next couple of months, but it does show benefit. So it doesn't stop the disease, but it helps those folks to live better and to minimize the impact of symptoms. Number two is stimulating their brains, so trying to avoid that social withdrawal and isolation. Just the act of getting out of the house, seeing different people talking, keeps some of those brain signals going. And the third thing is that there is some evidence to support that eating, changing your diet towards something called a MIND diet, M-I-N-D, or Mediterranean diet, can help the brain to at least have the nutrients that it needs to function optimally. But the benefit is slight. You know, it doesn't really stop the progression from getting worse.